Good morning, everybody. My name is Jo Jerome. I'm CEO at Thrombosis UK. And today's patient information session is also in collaboration with the Menopause charity. Now, this is a first for us, and we are really excited to welcome both Dawne, who is a patient advocate, has worked with Thrombosis UK for a very long time, raising awareness, raising funds, even written a book called Trekaga, the Moroccan Way, around her life and her adventures living with thrombosis, and also Dr. Louise Newson, who is probably the most well-informed and passionate doctor I've ever met about the menopause and HRT, and we are so fortunate to have Louise and Dawne here today. We've come to listen to them, so enough of me, and it's my pleasure to introduce and to pass over to Dawne to talk about her experience. Thank you, Dawne.
Thank you, Jo, and good morning, everybody. It's wonderful to hear that there's been such a good response. And I'm just here to tell you about my experience as a thrombosis survivor. My name's Dawne Archer. I'm 61 years old. And my blood clot experience goes back to the age of 26, when without warning, I woke up one morning with severe pain. I now know that was in the back of my lungs, but at the time it just felt like it was in my back. And not really knowing what to do other than go and see a doctor who seemed rather bemused by it all and really not convinced of the amount of pain that I felt I was in. To cut the long story short, I was misdiagnosed with hepatitis and pneumonia, were both suggested. I know that misdiagnosis is not an uncommon experience. I laid on my sofa for 2 weeks at home, feeling progressively worse, and certainly was very shocked one morning when I kind of came to and my chest was rattling. That was because obviously I'd been laid down for all that amount of time, as you can imagine. But anyway, that took me back to the doctor. I begged to see another doctor, and I was immediately whisked off to the local hospital and diagnosed with a blood clot in my leg and in my lung. So I had a DVT and a PE, and I spent a good 10 days in the hospital. This was back in 1986, so things were a little different then. I wasn't allowed to put my feet to the floor, very different to these days. And I was on an IV heparin drip for 10 days. When I was discharged, I was just put on warfarin for 6 months. No explanations, no information, just off you go. And of course, we didn't have the internet then, so I didn't have the power myself to be able to go out and find the information I needed. In fact, I didn't really know what information I did need. So off I went, living my life just quite normally, with no idea that there may be any issues waiting in the wings. Fast forward to 2001, and I won't go into the details, you don't need to know them, but my dad died of a blood clot in his lung. It started with a DVT, which wasn't resolved, and eventually he lost his life to it. And of course, at that point, I started to ask questions. It seemed very strange to me. I was talking to lots of family, which you tend to do at these times, and it became obvious to me that on my father's side, there were frequent incidences of sudden death, sudden unexplained death. I'm sure back in the day it was probably put down to a heart attack, but on reflection, I think that probably blood clots were the cause. And certainly my uncle died at the age of 32 very suddenly. I started asking questions without knowing what questions to really ask. My doctor was sympathetic but unconvinced there would be an issue. And when I came back as positive for factor V Leiden, she was quite surprised. Even then, it didn't really sink in what it meant or how it would affect my life. We came to the conclusion that if I was flying on a journey of over 4 hours, then I should self-inject with heparin and get up, walk around, all the advice that we're all given these days. And I did that. Just a little bit about my life in general. I'm a an incurable traveller. So I put myself, I suppose, at risk a lot by the amount of travelling I've done, both flying, long car journeys. But I have to say that all that time, I was a pest on an aeroplane, getting up to walk around, much to the air crew's disgust at times. And if we do car journeys, then every hour and a half we stop. I run around the car a few times, climb back in, and off we go again. So factor 5 Leiden, it has affected my life. And since then, I've had more tests done, and it would appear that I have inherited this from both of my parents. So I'm homozygous, which puts me at very high risk in any situation that would be a risk for anybody else. Sometimes up to 88 times more at risk. So yes, it does affect my life, but it doesn't stop me. I'm 61 and still, well, except for COVID, which has stopped us in our tracks, still traveling. And as Joe said, back in 2012, I did a trek even through the Sahara Desert to raise funds for Thrombosis UK. And that's my mindset. That's how life to me should be. You go off and do your thing, and whatever there is in the background that may be an issue, you try and deal with it and put it into the pot and deal with it. The difference these days is that we have the internet and the ability to get more information, and that to me gives you power. Information gives you power over your situation. Things have changed in the last 10 years because of my age. I started to go through menopause at 50, or perimenopausal at 50. There wasn't an awful lot of information about, but I had always been told that hormonal treatment was a no-no because of the clots. That was it. It was just a blanket ban, really. And I managed, I put my mind to it. I was going to get through the menopause without taking anything, and certainly not looking at HRT. About 4 years ago, certain things were starting to creep up with me, and I had to go for a smear test, and they couldn't do it. It was extremely painful, and I realized then that I had some issues that I had to deal with. And I did a lot of research in as far as I could. The problem I found is that there's a lot of technical stuff out there, but for the likes of me, who's not a medical person, it's not always easy to interpret. I took the advice of gynecologists and hematologists, and I say that in the plural. I found a very good gynecologist who gave me extremely well-informed opinions, but as soon as I came across a hematologist, it was a no-no. It was like the wall came down. HRT, blood clots, it's not going to happen. And I couldn't get round it with anybody. I saw several hematologists and they all had exactly the same opinion. You mentioned estrogen, no, it's not going to happen. So the upshot of it is that I use topical estrogen in the form of pessaries, and I'm on apixaban to counteract the effects of that. That's my current situation. I don't really know what more I can tell you about that, because that's how it is for me. I'm fine on the apixaban. Things have sorted themselves out, but that's my situation. So can I hand over to someone else?
Of course, thank you, Dawne. That was very helpful, and I'm sure
Okay?
much of what you shared will be resonating with people who are watching.
I think so.
But what will be interesting now, if Dr. Louise is able to share the information that I know she has, and then we can start on our questions. Thank you.
Yes.
Thank you, Dawn. That was really good, and I'm sure, as Joe said, resonated with lots of people. So I'm here as a physician, and I'm really honoured to be invited here today. Actually, Thrombosis UK are doing as a charity is incredible, and I know there's so much more that needs to be done, but it's really brilliant, and it's a real honour. Actually, I'm the founder of the Menopause charity, which is going to be officially launched next week, actually. So we've got some very exciting plans for that. So just for my background, I hope you can see these slides okay. Please tell me, Joe, if you can't. I'm a hospital physician. I trained in hospital medicine, and then I went into general practice about 20 years ago now. And I was a GP for many years, and now all I do is live, breathe, think about the menopause. And I run a menopause clinic in Stratford-upon-Avon. It's actually the largest menopause clinic in the world, and very sadly it's a private clinic because none of me or the 41 doctors that work here with me, all the nurses, can get jobs in the NHS as menopause specialists because there are no provisions for good quality menopause care, and we've applied and tried, but there isn't any funding for menopause clinics where we live, sadly. So just my declarations, I don't do any paid work with any pharmaceutical companies. I am a director of the clinic. I also run a not-for-profit company doing research and education, and I'm a director of the Balance app, which is a free app that anyone can download, which gives lots of evidence-based information to women, as well as the opportunity for women to join a community and to monitor their symptoms. And like I said, I'm the founder of the Menopause charity. I do have one declaration though, in that I take HRT, and I actually wouldn't be working here as a doctor without it because I was really struggling with symptoms. So I'm just going to talk about a different patient. We've heard one story today, and this is another patient who I saw in my clinic. So when she was 52, she came and her periods stopped 2 years previously. And generally she felt dreadful. She was getting a lot of vasomotor symptoms, so hot flushes and night sweats, more than 10 times a day, which were really affecting her. And she'd often go to work with a bag of clothes because she had to change her clothes 4 or 5 times each day. She was explained that she was generally more tired and had less energy. She was experiencing muscle and joint pains, which were really affecting her ability to exercise. Migraines were a lot worse, a lot more severe and a lot closer together. And she said she just generally felt very anxious and very low in her mood. She didn't have that interest, that energy. She said life just wasn't enjoyable anymore for her. More irritable, she found that she was very short-tempered, especially with her family and her work colleagues. She had recurrent urinary tract infections and urinary symptoms, so she was often waking in the night to pass urine, going to the toilet a lot more frequently, coughing or sneezing. She'd often have a bit of a leakage, which she'd never had before. She was getting some occasional palpitations, and these worried her because her brother had actually died of a heart attack when he was 54. She had no libido at all, and she said it wasn't such a problem because actually having sexual intercourse was incredibly painful, and her last smear test she had was very uncomfortable, but she said no one gave her any advice or information, and she just thought that was part of getting older. So she was diagnosed with a clot. She had a deep vein thrombosis in her leg after a long flight coming back from Australia 5 years previously. And at that time, she was diagnosed with protein C deficiency. And she was always told, and that stuck with her forever, that she must never take hormones in the future. So she tried with this menopause. She'd known that she was menopausal, and she tried various different lifestyle changes because she'd read on the internet how exercising might help, changing her diet might help. She tried some different herbal supplements from the over-the-counter. She'd even gone on and had some cognitive behavioural therapy, which helped the vasomotor symptoms a little bit, some of the flushes, but didn't help all the other symptoms that she was getting. She'd also been given antidepressants from her GP and had tried 3 different, and she just said they numbed her symptoms but didn't really help how she was feeling. So she was really struggling actually, and really struggling to work and to function as a woman. So she was desperate for some help. So the big question for me as a doctor is, should I be giving her HRT or not? So I'm just hoping in the next 15 minutes or so I can just help give you some evidence-based information. If you look back at the menopause, if you break down the word menopause, it's not stop men, don't come near me. It's actually meno is menstrual cycle, pause is stop. It's a look back in time, retrospective diagnosis. So officially to be menopausal, we have to have not had our period for a year. Now, many of us find we start to get menopausal symptoms when we're still having periods And that time of our lives is called the perimenopause, and peri just means around the time of. And that can happen sometimes for 10 years before the official menopause. If a woman has her ovaries removed in an operation or damaged by drugs or radiotherapy, for example, then she might have an earlier menopause. So the average age of the menopause in the UK is 51. But now in 2021, the life expectancy of women is 82. So that means there's a lot of us menopausal women around. And it's important because it means that around a third of our lives, potentially, we will be postmenopausal. And after the menopause, this is when our hormone levels are low, and they will stay low forever. And this is really key because we need to think about the menopause not just as something that causes symptoms as an inconvenience. It's actually a long-term female hormone deficiency with health risks as well. So this is a really silly question, I realise, because all women are directly affected by the menopause, but men are as well. Any man that knows a woman, whether it's at home or in the workplace, will meet and experience, if you like, indirectly the effects of the menopause. The vast majority of us will experience symptoms, and studies have shown around 25% of women have severe symptoms. I think that's an underestimation, and we know that a lot of women don't recognise many of their symptoms, such as the anxiety, the low mood, the memory problems, the fatigue, the poor sleep, as associated with low hormone levels. So if we think about estrogen, which is the building block of hormones, it's the most important hormone for women. We have cells that respond to estrogen everywhere. There isn't one cell in our body that doesn't have a receptor for estrogen. So this is important when we think about symptoms, but we also think about health risks. So if you think even in our heart, we have receptors for estrogen, so that can affect palpitations. It can also, without estrogen, you can get narrowing of the arteries, increased atheroma, increased risk of heart disease. Even in our muscles and joints, estrogen works as an anti-inflammatory, and so women are more likely to get joint and muscle pains without estrogen. And lower down at the bottom, you can see bladder. So it affects our urinary symptoms and our pelvic floor, but also our vagina. And so a lot of women find sex very uncomfortable, but some women find even sitting down or wearing underclothes very uncomfortable as well. So I've done quite a lot of work with West Midlands Police, and this is a pictogram we put on the back of every toilet door, actually, showing the myriad of symptoms that can occur. And one lady actually said to me in the police, I hate to go into the toilet because I am that menopause lady. I have all those symptoms, but I just don't know how to get help. And this is a real problem because women now are diagnosing themselves, but they don't know how to get help, or they know they need help, but they don't know who's going to give it to them. So the main reason that people come and see me in the clinic isn't actually the sweats and flushes, it's these psychological symptoms. And you can understand why women are being misdiagnosed with depression, but also why people are losing their jobs and sometimes losing their partners and their loved ones, because the psychological symptoms are really very significant for a lot of women. And the hormones estrogen and testosterone actually are very important for our brain function. So for me as a physician, obviously I want to make people feel better. It's very rewarding for people to feel better. But actually I worry about future health as well. I've already said that we live for around 30% of our lives without our hormones if we don't take HRT. So this has a big risk to our health. Once we don't have estrogen in our body, there's a rapid turnover of bone and a bone loss. So our inside of our bones look more like an aero bar than just a dairy milk if you break it. And you can imagine with all those holes, there's an increased risk of fracture and osteoporosis. So you can see this lady, general curvature of the spine because of osteoporosis. So her mobility is affected, but also her breathing and her digestion will be affected, and she's likely to be in pain, but also it's going to affect her mobility and affect her functioning day to day. The risk of heart disease actually increases by a factor of 5 after the menopause because the protective effects of estrogen mean that women under the age of 50 who are not menopausal are less likely to get a heart attack and heart disease. Women who have heart attacks over the age of 50 actually have a worse prognosis than men. Type 2 diabetes increases because there are metabolic changes that occur without estrogen, because it's very important in how our pancreas works, how our insulin works, and our glucose metabolism. Women are more likely to put on weight, and partly because our fat cells produce a very ineffective form of estrogen, and our body needs estrogen to function. So the only way our bodies can respond is by putting on weight often to try and give us any bit of estrogen it can. So obesity often increases after the menopause. I've already said about brain function, so it's no surprise that women are more likely to develop dementia after the menopause. And clinical depression as well. The low mood can often progress to clinical depression. And we also know COVID severity, so we know that women taking HRT are less likely to die from COVID than women not taking HRT. So this is quite a doom and gloom lecture, but I think it's important to just look at menopause as more than just something that causes symptoms. We can't do a blood test to diagnose the menopause. So I know in Boots you can do it by a urine test for hormones, and some clinics will offer a saliva test. They're a complete waste of time or money because our hormones fluctuate a lot. If a woman hasn't had her periods for more than a year, she's officially menopausal anyway, regardless of her symptoms. But we do this menopause symptom questionnaire for all our patients, and it's modified from something called the Green Climacteric Score. And if you go to my website, menopausedoctor.co.uk, and put in questionnaire on the search function, you'll see this. And it's also available on the app as well. And it's a very useful tool to monitor symptoms and also how they change with treatment. So for me, I really think that the menopause should be an opportunity. As a physician, it's very exciting to see menopausal women because I know I can transform and improve their lives going forwards. It's really important that us as women receive evidence-based information. When I was experiencing menopausal symptoms, I started Googling, and everything was telling me the risks of HRT, how dangerous it was, how it was going to give breast cancer and heart disease and clot and stroke. And even me, as a healthcare professional and a menopause specialist, I felt a bit scared. So I developed the Menopause Doctor website, which I fund myself, and it's full of evidence-based information. There are also lots of resources on my website, and I've written a book, and this is just a picture of the free app Balance as well. So all the work we do here in the clinic is based on guidelines. We've got the NICE menopause guidance that came out in 2015, the International Menopause Society guidelines came out in 2016, and also the ESHRE guidance, which are really good for helping women with premature ovarian insufficiency. So women under the age of 40 who have an early menopause. And it's very common actually, 1 in 100 women under the age of 40 will go through the menopause early. So just to summarize these guidelines, individualized care is very important. We're all different. We all need to be have an evidence-based approach, but based upon what a woman wants and sharing the available evidence and sharing any uncertainty as well. Women should also be informed of the benefits and risks of HRT so that they can make appropriate treatment choices. And it's very important to know that for the majority of women, the benefits of taking HRT outweigh any risks. Women can usually take HRT forever because it's just simply replacing the missing hormones. Obviously, lifestyle is important as well. There's no point me taking HRT, eating McDonald's 3 times a day and sitting on the sofa and not exercising. So it's looking at every aspect of our lives is really important. But despite us knowing that for the majority of women, the benefits outweigh the risks, in the UK, only around 12% of women take HRT. And actually, we're doing better than a lot of countries, which is really horrendous in my mind. I can't think of any other area of medicine that's so neglected. So HRT has caused a lot of confusion. A lot of people are very scared of it. So for years, the healthcare professionals, the media, women, we've all been given wrong information. So I just want to demystify it a bit for you. Before I talk about any risks, benefits are really important when we're considering taking something. Because it's replacing the missing hormones, women often find that their symptoms improve. If their symptoms don't improve taking HRT, it's because they're not on the right dose and type for them. We know the benefits outweigh the risks. And when you look at the long-term benefits, all these conditions that I mentioned, it reduces the risk of, which is no surprise because you're just replacing the missing hormones. And this is really important looking at our future health. So it's only 3 letters, HRT, hormone replacement. Actually, when you start it in the perimenopause, it's not even replacing, it's just topping up the missing hormones. So there are different types, there are different doses. There is estrogen, I've already said, is a really important hormone. Women who have their wombs still need to take a progesterone, and testosterone is actually another hormone that we produce around 4 times more of compared to estrogen. There are pills, patches, gels and sprays. I've put pills not in bold because I don't prescribe them first line, and I'll explain why in a minute, but the patches, gels and sprays, which are available on the NHS, are the go-to types of estrogen. So why is so few women taking it? Everyone is worried, and it's a lot easier if you're worried about something to ignore it. But we shouldn't be ignoring it anymore. We've got really good evidence based for decades that we need to be looking at and exploring. But this is why we're scared. In fact, this article came out about 2 months after I started taking HRT. It was on one of my daughter's birthdays. I read the paper and I just thought, oh, I've just started to feel better. Now I need to take my patch off. But then I went back to the original article and read, and it didn't tell us anything we didn't know already. So I kept my patch on. But then I go to the NHS website and it's telling me about finding out about HRT, about how it can help symptoms, great, different types, great. And then it says the main risks and side effects. So it doesn't even mention the word benefit here. And it also says about how it can raise my risk of breast cancer. And then it also talks about blood clots. So this is quite scary. There's nothing telling me that it's going to reduce my risk of heart disease and diabetes and dementia, which are the 2 conditions that kill most women. And it doesn't say actually anything else that might reassure me that not every type of HRT is associated with the risk of breast cancer or clot. So if you look at breast cancer, this is one of the reasons that most women are scared of HRT. We know breast cancer is very common. It affects around 1 in 7 women. When I was at medical school, it was 1 in 12 women. And then when I was a junior doctor, it was 1 in 11. And it's become more common, not because more women are taking HRT, because actually less women are taking HRT than they did in the 90s when I was a medical student. It's often because of lifestyle changes, actually. And we know a big risk factor of breast cancer is increasing age. As we get older, more likely to get any type of cancer. Family history, some women do have a genetic predisposition and have certain genes that increases their risk. But the bottom 3 in pink are so-called modifiable risk factors. So obesity, drinking alcohol, reducing exercise, these all increase risk of a woman experiencing or having breast cancer diagnosis. Now we know that women, I've already said, tend to put on weight during their menopause. A lot of women drink more alcohol to numb their symptoms. And a lot of women stop exercising because of the way they're getting muscle joints and pains. They just have reduced motivation. So actually women often in the menopause are increasing their risk of breast cancer, but they're saying, oh, I don't want HRT because I'm worried about the risk of breast cancer. So when you look at HRT, certainly when women are young, when they've had an early menopause under the age of 45, any type of HRT is fine. There's no increased risk because it's simply replacing the missing hormones. If women have had a hysterectomy and only have estrogen, they have a lower risk of breast cancer, which is what people, not quite what people think, but we know from following women up for over 18 years, women have about a 25% lower risk of developing breast cancer if they only have estrogen. So if they have a progesterone, then there are different types of progesterone. The synthetic older type progestogens, which usually come in tablets, seem to have a small increased risk, but it's only very small. There is this micronized progesterone that's available in the NHS called Progestogens, which is the same structure as the progesterone we produce ourselves and has no risk of breast cancer. But even the worst type of HRT, if you like, the risk of breast cancer is lower than a woman whose risk of breast cancer is drinking a couple of glasses of wine most nights. Now, wine bottles do not have a big warning saying risk of breast cancer because the risk is incredibly low. And so, but it's higher than taking HRT in its worst form. So I hope that will just reassure some of you about the risk of breast cancer. So obviously I'm talking about risk of clot. So what about clot in women in general? I'm sure many of you know that the incidence of clot increases as we get older. And there are other risk factors, as you know. So if someone's had a clot in the past, if they're overweight, if they've got some of the inherited conditions, and also oral contraceptives increase risk of a clot. Oral HRT, so when I say that, I mean the estrogen as a tablet is contraindicated, the same as oral contraceptives are. So absolutely, women with an increased risk of clot should not be given tablet estrogen because there is an increased risk of clot. If you look at the studies, we know that the risk increases with tablet estrogen. Most studies say it's a double increased risk, and this risk is greatest in the first year of taking HRT. Women who've got a thrombophilia, actually that risk is even higher. But if we give estrogen through the skin as a patch, gel or spray, it goes directly in through the skin into the bloodstream, and there is no increased risk of clot. Vaginal estrogen preparations can be given in conjunction with HRT, or they can be given on their own. The dose is incredibly low. There's no systemic absorption, so that means there's no clot risk at all with vaginal estrogens. Around 20% of women who use HRT still experience some vaginal dryness, and so those women use vaginal estrogen as well. But if a woman only chooses to use vaginal estrogen for localized symptoms, then there's no risk of clot, even if she has a thrombophilia or a condition that's increasing her risk of clot. So if you look at the difference between oral, so tablet estrogen, to transdermal through the skin estrogen, when we take estrogen orally as a tablet, it then gets digested and metabolized, and it goes through the liver. And this means that it reduces the protein synthesis. So all our clotting factors are triggered by the amount is affected by having tablet estrogen. It reduces antithrombin 3 levels, and it activates the coagulation cascade. It also induces a resistance to activated protein C. So this means that oral estrogen is very pro-thrombotic, more likely to cause clots. So that's why it cannot be used for women with an increased risk of clot. And even a low dose estrogen given as a tablet still has these effects. So when it's given through the skin, studies have shown it's not associated with a risk of clot. Even one study looking at women with factor V Leiden mutations showed that there wasn't a double increased risk of clot with oral estrogen, a 25-fold increased risk. And if you compared it with transdermal estrogen, there was no risk at all. So that's very safe. So we know that estrogen through the skin is safe. So what about the progesterone part for women who have a womb? Well, the progesterones or the progestogens, or the synthetic progesterone, they are needed for women who've still got their womb. Now, the progestogens are synthetic, and they have a risk of clot as well. And the risk increases by about 50% if a woman are using a tablet estrogen with a progestogen compared to estrogen alone. So it's a double whammy, really. In some of the combination tablet HRTs, they've got tablet estrogen and a synthetic progestogen. So you've got an increased risk with estrogen, increased risk with the progestogen. So it's absolute no way. Women cannot have those types of HRT. But this is very different with a micronized body identical progesterone. So this is it, the Utrogestan, it's called in the UK. And it's derived from the wild yam plants, so not related to horse's urine, which some of the old types HRT were. And it's the exact duplicate of the progesterone produced in our bodies. So we call it body identical. It can be taken orally or vaginally, but either way it's taken, it won't increase risk of clot. So it's very, very safe, even for women who've had a risk of clot in the past. So lots of information to take on board. So we've written, collaborated with Thrombosis UK, and we've written a patient information leaflet. There's lots of booklets on my Menopause Doctor website, and this is actually the only one that we've put in some references. So if people are still unsure, they can go back and read the original references. So it's available on my website and also on the Thrombosis UK website as well. And on my website, we've got a story from a patient who very kindly wrote her story, who's got antiphospholipid syndrome, and she has recently decided to take HRT, and she's talking about her story. There's an amazing program that's coming out next Wednesday, which I just to alert you of on Channel 4 at 9 PM, which is well worth watching. I think it's probably the best thing that Davina's ever done. So we go back to Ruth, the lady who I mentioned at the beginning of my presentation. So I talked to her about the benefits of HRT, the health benefits, the benefits for her symptoms, and also about no risk, giving it in through the skin with a natural body identical progesterone. So I gave her the estrogen gel, which is simply applied and rubbed onto the arms or legs. Started with a fairly low dose, and she gradually increased as she was still getting some symptoms. She was given the Micronised progesterone as a capsule to take each evening. And because she had a lot of vaginal symptoms, I also gave her some Vagifem, which is this small dose of a vaginal tablet of estrogen. And 3 months later, she felt a lot better. She was enjoying her life. And she said, I've also regained my energy levels, and I have joined a gym. I can actually go through the day without feeling like I'm going to fall over with exhaustion, which is lovely to hear, but I know I'm also improving her future health as well. So just some take-home messages. It's really important that we all receive individualised care. And a lot of healthcare professionals have had no training in the menopause, and a lot of the work I'm doing with the Menopause charity is to change that. But if you don't receive evidence-based information from your first doctor or healthcare professional, then you should challenge it and try and see someone else. The menopause can lead to many symptoms, and often these symptoms change with time as well. And there are real health risks of the menopause which shouldn't be ignored. I hope you can be reassured that most types of HRT are very safe, and women who have had a personal history of a clot or a family history of a clot can still take most types of HRT. We should be given evidence-based information. So finally, this is just links to various the websites that I'm involved with. So I know that's been a lot of information, and I've gone through things fairly quickly, but I hope that's helped to demystify some of the perceived problems with the menopause and HRT. So thank you.
Thank you, Louise, so much. I have to say that must be one of the most informative and enlightening talks I have ever listened to.
Oh, thank you.
It is, I mean, I think it's an area where, and I think perhaps others will agree, that there is so little reliable information, and it's a subject you can talk about perhaps with friends, but you don't know what. So you don't know what are symptoms, how long they last, should I go to the doctor, should I not, all sorts of things. And your talk has been a complete eye-opener and so great. Thank you. I don't want to talk anymore because we have so many questions, and it's only fair that we address these. So I'm going to first go to the questions that were pre-submitted. And it's going over some of the things you have explained already, but to clarify. So it's about someone or individuals who had a DVT many years ago that was linked to the contraceptive pill and pregnancy. And they took Clexine, and they wondered, because of this history, they were then diagnosed with factor V Leiden. Is it likely that they could at least be considered for HRT given that history?
Absolutely, and I think what's really confusing actually for a lot of women and healthcare professionals is if you look at the NICE guidance that I said, the NICE menopause guidance, it will say if women have a risk of clot, then they should be referred to a haematologist. Now, I have every regard for haematologists, but a lot of haematologists haven't had any menopause training. And so they will think all types of HRT are the same as contraceptive pills. The ones that are more knowledgeable in that area will say, yes, it's absolutely fine. Like I know Professor Beverly Hunt will just say, yes, that's fine, but it's not really a good use of her time. She should be doing other types of hematological consultations. So in my mind, you don't have to be referred to a haematologist. And I see a lot of women who have gone from 1 to 2 to 3 different haematologists, and they've all just confused people. The other thing that's very confusing is that if I, this is the gel here, if I open the packet, the insert will tell me there's risk of clot, there's risk of stroke. And so even if I get this from my doctor and I'd had a clot, I'd be thinking, no, I can't use it. And I can't begin to tell you how many times I've emailed the MHRA to try and get this changed, because we've got really good evidence now. And even if you, in medicine, if I'm not sure about something, I'll go back and think about the physiology and the pathology. We know that the mechanism of action is very different when it goes through the skin. So therefore it is safe. But also this warning is linked with our prescribing. So when I try and prescribe through the computer some of this gel, it will come up risk of clot, risk of stroke. So therefore doctors will go, oh no, actually, sorry, I can't do it. So this is why it's really hard. But I really feel strongly that women should be empowered. We're not stupid as women. We can empower ourselves. So I think if we have the information, and certainly if you go to your GP, have the booklet that from my website or Thrombosis UK, they're the same, and say, look, actually, I've read this and it's referenced. And if you don't want to prescribe it now, have a think and a read, and I'll come back in the next appointment, and then can I have it? So there are barriers, and I understand why there are barriers, but actually for women, we want the best treatment, and we deserve the best treatment.
Definitely, definitely. And it makes, as you say, such a difference to your life now, but also in the future. And I think really this is picking up on what you've just said as well. It's a lady who has many symptoms. She was given antidepressants, but she didn't take them because she really didn't think that was the solution. She was advised to see a female GP because they felt that was better. She eats healthy diet and exercises, but she feels dreadful with hair thinning. What is with the doctors still refusing to consider HRT? She said, I'm 60 years young. What can I do? And I think perhaps you mentioning about this leaflet, because this leaflet, one of the things I think is very empowering about it is all the references on the back. So,
and I think also to have, Professor Beverly Hunt, I hold in very, very high regard. And I think to have her to okay it, I'm a medical specialist, she's a haematologist. So we both have different knowledge, but it overlaps. And I think the other thing about all of this is about patient choice, actually. And we know the GMC updated their guidance about consent last year. And as long as we have, we're given information about the risks and the benefits, we are allowed to make that decision as consenting adults. So even if there was a risk, we could still say, I want that treatment. And so if doctors push back, I'm not sure as a doctor I should be pushing back on anyone that wants something. We should have a good two-way conversation about it. On my Menopause Doctor website, there is actually a letter. If you just put in the search letter, it's a template of a letter that you can share with your doctor to really say, why is it that you're refusing to give me HRT? And I've read some information and I would just like to have another consultation. It's not an aggressive, nasty letter, but it's quite hard. I know when I see my GP, I get a bit sort of stuck for words and I'm a bit in awe of him because I know he's really busy. So it can be quite challenging and threatening, actually. So this letter has worked a lot. We used it a lot in the police force for women who were really struggling. And the doctors often then phone them up and say, gosh, I had no idea, I didn't realise. So it's doing it in good ways, actually, because you don't want to rock your relationship with your healthcare professional.
I agree. And I think it is a very calm way of doing it, but it's empowering.
Yeah.
And asking for the information that you are entitled to and you should have for your own healthcare. Just going on to the risk of clots. Obviously, you've highlighted that most HRT do not increase the risk of clot. And is that true for people who have had a blood clot a long time ago or even just a few months ago, so regardless of how long ago it was?
Yeah, it's exactly the same. And actually, when you look again, breaking it down to the physiology and pathology, actually there is some evidence that transdermal estrogen, so the body identical 17-beta estradiol, actually is anticoagulant almost. It helps relax the blood vessels. It's very good because we have estrogen receptors on the endothelial, so the lining of a blood vessels. Actually, it can be anti-inflammatory, so it can reduce clots a little bit. So when you look at the studies, actually, it's not neutral, it's slightly good. So it sort of can be even more beneficial. Now, we see a lot of women, as you can imagine, who've had clot in the past, and we had one recently who's on HRT, then she developed a clot in her leg after going on a flight. And so we got this horrible letters from her GP to say, how dare you put her on HRT? Well, of course, anyone who's had a clot has always got a risk of a clot. And she had a provoked reason because she'd been on a flight. So it's not going to prevent women from having a clot. I've already said it might reduce risk a little bit. And it's a bit like the whole breast cancer thing. 1 in 7 women will develop breast cancer. So that means 1 in 7 of us taking HRT will develop breast cancer. But it doesn't mean the HRTs cause the breast cancer. And that's where we have to sort of differentiate.
Yeah, we have to remember that background clot level. Yeah. Dawne, just to ask you, your conversations with your doctors, how did you find, was there anything that you found that was empowering or helpful to share with them, trying to take forward conversations about your symptoms and potential treatment or a major challenge?
Yeah, certainly. I asked for, I looked around for information. I came to Thrombosis UK, got some information. I went, did my own research and spoke extensively to the gynecologist, who was extremely knowledgeable, but obviously not a blood clot expert. But it didn't make any difference at all. I just found that with a haematologist, the shutters just came down straight away. So much that Dr. Louise has said rings true. I've been sitting here, I know I had my video off, but my head was nodding and agreeing with so much of it, because that's exactly how things have been for me. And it's a bit of an eye-opener to hear all this, to be honest. Yeah, what can I say? It's very hard to work your way through the information that's available. A lot of it's very technical. What I like about the leaflet that you've done is that it's all explained in terms that, you know, someone who's not a medical expert can understand and appreciate. And as has been said, we're intelligent people. We're able to make our own decisions, to weigh up the information for ourselves, and to be treated that way by your health professionals is really important, but it doesn't always happen. And I very much identify with the idea that when you are seeing these health professionals, be it your own doctor or a specialist, you can quite often be tongue-tied unless you're lucky enough to get someone who can draw you out, can bring out what you want to say, because, you know, no, there's a bit of a menopause symptom, isn't it? You know, forgetting my words, typical. But the white overcoat kind of feeling, you know, you're in all of these people.
I think, and from our experience in other areas as well, so even most recently of access to vaccination, a calm letter, such as Louise is described and is freely available on, is it the My Menopause website?
Yes,
the My Menopause website. Along with that leaflet, I think could be good door openers. And again, from experience, we're going to healthcare professionals who we do respect and they do know a lot, but they're not necessarily specialists in certain areas for good reason. And so I think sometimes a leaflet such as the My Menopause leaflet is really helpful because it explains it in very simple terms rather than all the technical jargon that you have to then go and look. And that's across the board for anybody who is non-specialist, such as ourselves knowing ourselves or our clinicians knowing us. So I think perhaps there's been a lot of questions in around access and convincing. I think your letter and our joint leaflet together could be a good starting point.
Can I just interrupt and just say that I think the letter is a very good idea, because it gives the health professional a chance to really consider what you're saying, rather than having someone in front of them who's maybe a bit, you know, het up and a bit flustered and maybe not explaining themselves properly. I think that's a really good place to start. Yeah.
There's also been some technical questions in about getting, now I might say this incorrectly, but is there a level or range for estrogen, or does that number depend on the individual? And it's sort of linked also where people perhaps get breast pain if they try to increase their dose of estrogen. Is there a certain level for each individual, or how does that work?
Yeah, I mean, everyone's different. What we do is try and achieve a physiological response. So we want to have the estrogen enough to help protect our hearts, our bones, our brains. Too high a level, actually, no one's going to die from having too high a level of estrogen. If you think when women are pregnant, their levels go in their thousands. We usually have levels in the hundreds. We do measure estrogen levels, but we don't get too het up about it because it's more about symptoms. And some women need a lot more, sort of more pumps, or sometimes people use 2 patches. And people think, oh gosh, they're on too much, but it's not what they're using externally, it's what goes through into their body and how their skin sort of absorbs it, if you like. Some women do get side effects. The commonest side effect is breast tenderness initially, which usually settles down. Sometimes that can be the progesterone, actually, not the estrogen, and it's sometimes a balance. And I touched on testosterone initial, and some people find once testosterone's added, breast tenderness can reduce as well. Some people can get some irregular bleeding or spotting, and that usually settles as well. And this is why it's really important that people get individualized advice. And things change. You know, when people start the perimenopause, their hormone levels have only just dropped, and then suddenly their own hormones will drop more, and then they'll need more to replace. So the dose is quite fluid, and that's why it's really nice to have the pumps, for example, because people can change themselves and people can be in control. You know, we don't want to be going back to the doctors all the time asking. We want to just get on with our lives really and do it ourselves.
And obviously there's a range out there which I wasn't aware of, so amazing. If you're allergic perhaps to a patch, is it worth then trying something else, or is that?
Absolutely. So, and it's really good. So there are different patches with different manufacturers. So that means they have different glues. They've all got the same estrogen in them. And there's also different gels. So there's the pump that I showed you, but there's another one that's in a little sachet. And now we've got the estrogen spray as well. If people are getting a lot of irritation to the patch, or it's not sticking well, some people say they have to put a plaster over it, then it's not good, because if it's not sticking well, you're not getting good, reliable absorption. So it's always worth changing from one to another. And we sometimes use a combination. So sometimes people use patches and then they top up with a bit of gel on days maybe where they're sort of dipping and feeling some symptoms. So it's a bit like finding a sort of good pair of shoes. You might try a few and then you'll find the ones you want to wear every day.
And I think also, obviously, for any of us, it would be initially addressing the symptoms that we're suffering, but longer term, if we have any other issues, as you said, there are benefits long term for that. And somebody's asked about the benefits around bone density, especially where they've got problems already. So with the right HRT that's safe for you, can that also help protect you longer term against bone density?
Absolutely. And we know even low levels of estrogen actually help improve bone density. We've got a bone density DEXA scan here in the clinic because it's very hard actually to get them. And one of the reasons I take HRT is I'm really, really worried about osteoporosis. So I strongly feel we should all have a baseline scan, men and women, because many women and men don't know they have osteoporosis until they've had that hip fracture. None of us want that. So it's really important. And it's not just about HRT, it's about, do I need to change my exercise? Do I need to eat differently? How much calcium do I have in my diet? We all should be taking vitamin D. But, you know, osteoporosis is a silent killer. 1 in 2 women over the age of 50 will develop osteoporosis. 1 in 3 will have an osteoporotic hip fracture. And those are women obviously not taking HRT. So we need to really protect and look after our bones.
And you're quite right. Once you stop or having issues with mobility, other things are much harder as well. You mentioned about the Mirena coil. Is there any risk of clot associated with that?
It's a really good question, because obviously it contains a synthetic progestogen, and I've already said synthetic progestogens avoid. The dose is incredibly low because it works locally on the lining of the womb. So I can't really, unless someone had someone had such a sort of bad clot history, they would be on an anticoagulant anyway. So in which case it doesn't matter, they can have tablet estrogen. If their risk is low, then actually it's fine. You know, you've got to put things into perspective. And actually the Mirena is really good if people have heavy periods, if they're perimenopausal, or if they need contraception, and it can be used for 5 years. So yeah, it's fine.
Okay. And then a more technical question again is about, could you clarify the difference between the body identical versus bioidentical hormones? I think GPs don't understand the difference. I didn't say that, I'm quoting that.
No, and it's very complicated, because body identical means it's the same. If you look down the microscope, it's exactly the same as the hormones we produce ourselves. Bioidentical means that as well. So what we often do is say it's regulated bioidentical. So the HRT I prescribe is regulated. So it means that every prescription, I know exactly what it is. It's being tested. Each dose is the same. Compounded bioidentical HRT is what's sold in a lot of other private clinics. Now, this is compounded. So it means people have got like a back pharmacy and you make it up. And so every prescription is slightly different, and it's not analysed, and it doesn't have the same regulatory processes. It comes under as a food supplement rather than a drug, if you like. So the way you know the difference is, firstly, they're incredibly expensive. You know, this stuff is dirt cheap. It costs the NHS about £4 a month. Whereas if you're spending hundreds of pounds on your HRT, you know it's probably compounded bioidentical. A lot of these clinics will give lozenges, or they'll give progesterone creams. There's no evidence that they work, and actually they could be harmful. We see a lot of women who've gone to these clinics and they're still having symptoms. We do their estrogen levels and they're really low. A lot of them have been given testosterone at really high doses, which again can cause side effects and problems. So it's a marketing term actually, and they should not be used. They're very big over here, but also especially in America and Australia as well, because people have been scared of HRT. So they're saying, oh, they're more natural, but actually they're not at all. And now we've got these regulated bioidentical, body identical HRT, if you see.
And another, is there same increased risk of clots if you take a body identical tablet for estrogen only?
Yeah, there is, because it's the way the estrogen's metabolized through the liver. So yeah, I would just completely avoid. And actually, I never really give estrogen as a tablet to any woman, even if she has no risk of clot, because there's just more reliable absorption. You can imagine if you have a tablet, you've got to, depends on what you eat. The bioavailability is really varied, whereas when you put it through the skin, it goes straight in. So it's always better every time actually to have it through the skin.
I'm sorry, all these are for Louise, but obviously they're quite complex questions, this one, about somebody who's had a hysterectomy and ovaries are in place through the menopause. Is there still a benefit from optical estrogen for muscle pain?
Yeah, definitely. So when people have had a hysterectomy, they can have an earlier menopause, even if they've got their ovaries in place, because it's just the blood supply to the ovaries and the womb is similar, and it can be disrupted really with the hysterectomy. It's very difficult to know when you're menopausal, of course, because you can't monitor your periods. But muscle aches and pains are very common. We see hundreds, if not thousands, of women who've been misdiagnosed with fibromyalgia actually and chronic fatigue. And estrogen can have an effect, but also testosterone is an anti-inflammatory in the muscles and joints as well.
So I think we've answered most of the questions, and really as a takeaway message, what would you say to individuals, firstly, who think they should consider HRT, and secondly, on what HRT is safe for and what ones shouldn't be considered?
Yeah, I think the most important thing is getting the right information and knowledge. So have a fertile around on the Menopause Doctor website. There's lots of videos there, because sometimes reading, it's a lot of information. So there's videos there. I do a weekly podcast as well. And just try and assimilate the knowledge before you go and see a doctor. Download the app Balance, it's free. That's got lots of information on it as well. And just, it's really, certainly what we want to do with the Menopause Charity is change the narrative. We need to think about it as a hormone deficiency. So therefore, let's think about how we can replace. Let's think about why we're not taking HRT, because for the last 20 years, everyone's been a bit scared and thinking, should I take HRT? Well, we should really think who shouldn't be taking it. Women who've had an estrogen receptor cancer, especially breast cancer in the past, maybe shouldn't take it in the first line, but actually estrogen used to be a treatment for breast cancer. So it's very complicated. So we've again got a booklet that we've written for women menopause who've had breast cancer. So it's just changing that narrative, and it's very hard to change when we've all been brainwashed almost about how dangerous HRT is. But we wouldn't have this conversation if we had an underactive thyroid gland. We would just take thyroxine. We've just got to see it as other hormones and just try and forget everything you've been told in the past and start afresh actually. And then I think you're empowered as well. And that's really important.
Thank you. And Dawne, for you, I think we both probably are in awe of the information we've learned today. But having gone a long journey with thrombosis and through menopause and hearing the information today, what empowerment do you think we can take away from this with our doctors? What would you now consider being able to do?
Well, I guess my attitude has always been that knowledge is power. That gives you the power to make decisions about your conditions. And that's so important to me. And I think to many people. I've a feeling there's a lot of people out there who've been nodding along like I have been, because so much of what's been said rings true. But we've just been presented with a huge amount of information that we can go back to and that we can research further and that we can take forwards with us, take them to our doctors and go in feeling, I think, a sense of strength in knowing that there are other people in the same position or similar positions with similar needs to make a change. I wish I'd heard all this 10 years ago.
I agree. And I can see in the comments as well, as somebody with a wide family history of clots, but also of osteoporosis, and just saying that it's reassuring to know that there are options.
Yes.
If there are a few questions that have come through that we haven't fully addressed or managed to address, I will try to seek answers and reply to those people, okay, or they can email me. But I know we've come to the end of our time. I just want to thank you both so much for this fantastic discussion and learning opportunity. I know this is going to be shared many times, and I hope we can keep the focus on this to make sure everybody is aware there are options out there and you can feel better and it is possible to be treated. Thank you so much, Louise. Thank you so much, Dawne.